Yeah.
You can sit at the big boys' table.
As long as it's away from the camera. It's fine.
No, we can't see you.
And they can't hear me.
Really. I'll sit up.
Give it one more minute. See if any 4 more doctors show up. Oh, see? There's 1. There's 2.
We thought you were kidding. You have a plan.
Good. We're still shy. I mean, we do 9 groups.
8 is a quorum.
Is it 7? 7. We're 1 shy.
Who can we call?
Yeah.
It's on the phone.
Or can we do virtual? Somebody would call in? No?
They have to open up their home to be available for a meeting according to New York State. So, which, I mean, I guess they could do.
Yeah, but it has to be published 10 days before.
Oh, they have to publish 10 days before that they're opening up their home. You know. All right. So Pam is away. So with the help of Bill, I will limp through trying to fill her shoes. So attendance. Pam's out here. Dr. Larson. Stu Miller. Dr. Lino. Dr. DeCassard. McKinley. Dr. Kim. Dr. Chong McGurdy. Medor. Stupple. Templeton. Green Hut. Thompson. Dr. Mage. Rodriguez from Putnam. Dr. Brown. Dr. Cohen's out. Dr. Santos from Shannon. Felice. Cruza. Larson. Show up twice. All right, so we're 1 shy of a quorum, which is tragic. We have the minutes. We have a copy of the minutes.
They were posted, and the video is also posted.
So accept them?
Yeah.
Without a quorum?
Cannot.
I don't think we can, right?
No. You can't vote on anything without a quorum.
Supraglottic pilot program update. All right, it's going pretty well. We have about 200. Does not include today's stats that just came in, or most just came in. We have about 287 insertions since inception. There's 51 that are not in the state report.
For folks that don't come to this meeting regularly, what are we talking about?
Sorry, yeah, so this isn't an iteration of the iPhone. This is the insertion of an iGel supraglottic airway device by BLS providers. We started a pilot study to determine the feasibility of BLS providers to do this on their own. It was brought forward by Greenville Ambulance to the region. We sent it up to the state as a study. We started it in 2003. In March, we started collecting data. And after pulling our hair out and turning gray and all kinds of things, we're finally getting some kinds of data to come in. So if you all heard from me asking about your data, that's why. We have about 287 insertions. 268 were defined as successful, so that's about 93%. We're looking at the 19 that were not, and to whether they were pulled or not pulled, or what the issue was with them. Again, 51 aren't in that number yet, so there's a possibility of having over 300 insertions to look at. We have mostly no adverse events whatsoever with these. Intel CO2 has been going great. The typical size is a number 4. It's about 6 minutes from at patient to insertion of the devices. I have some ROSC and outcome data here that I'm happy to send out, and we do send these out quarterly to all of the agencies that are involved in their medical directors and regions. It looks like the median age is about 68, and twice as many males doing cardiac arrest than females in this particular study. Out of all the regions, Central New York is the highest, Hudson Valley is the next, then Susquehanna, Monroe, Livingston, Mid-State, Finger Lakes, and then New York City for those participating. It's going really well at the last CMAC. They suggested that we wrap this up, which I agree with, and that we try and look at what this might look like moving forward for the state and BLS providers. The idea is that we're going to present at the next CMAC SEMSCO and move to make this the next BLS adjunct for agencies to utilize at the state level as we work towards making it a part of the national scope of practice. And so that will work by having all the same parameters of program in place. That has to be regionally approved. Providers can do it if trained and equipped at their agency. They'll have to use end-tidal CO2 and all these different components of this. And then we will let the ship sail off into the sunset.
Do you have the ROSC data in front of you?
So we have, I have ROSC and outcome. So ROSC, 182 no, 11 yes, sustained for 20 consecutive minutes, 5 not applicable, 51 yes prior to arrival of the ED, 3 not recorded, 9 yes at arrival of the ED, for a total of 66 yes. For outcomes, 60 expired in the ED, 105 expired in the field, 23 ROSC in the field, 60 expired in the ED, 37 ongoing resuscitation, 26 ROSC in the ED, 9 not applicable or recorded, and 2 ongoing resuscitation by other EMS. Also remember that some of these are pronouncements in the field, and so they dropped an IGL that was successful, and the patient just expired in the field, and so they never made it to the ER or anything like that. But it was utilized appropriately.
Well, if you add up all the ROSCs, like, I don't know if you have it, like, in summary, like, what's the ROSC percentage? I'm just wondering if there's any actual outcome difference in terms of ROSC or actual survivability, which...
So
I
I have 66 as yes, but I think we would have to look at doing it statistically more. And I don't think we can just count it because of confounding factors and things like that. And whether the person would have been lost because of this or not, or would have been lost anyway in some way, shape, or form.
True, but I mean, ultimately, if you add up the data, and, you know, there's actually a greater ROSC rate overall or greater survivability, then that goes from changing it from being like a cool novel thing to like, you know, something more profound that would, you know, become nationally important sooner.
Yeah, and so there's a big debate about this at the national standards, and they had a number of paragraphs in the description of whether it should be included or not for scope of practice. And the big reason was that they didn't was because of the end-tidal CO2 monitoring of it. That was the biggest reason involved. And so if we require that, there's no reason why.
What's the reason why they're doing it?
Yeah, so we have a total of 66 with Ross and 88 that had either Ross and over ongoing resuscitations.
They survived the discharge, or they survived?
That I don't know because we can't get hospital data. So one of the issues with data is people doing PCRs with information and drop down to the narratives. And I'm not saying that's the biggest reason, it's just the first one on the list in terms of chronologically when you get from documentation to the end of it, from the to the end. Two is that it doesn't get through the agency to the state or the region and then to the state. Three, the data is mismatched, so I can't tell you how many of these come across as intubations versus supraglottic airways or other kinds of weird things. And then getting the data from the state back to the hospitals. Some hospitals don't accept the data. Some it gets to the hospital months later, some it never gets there. And then hospitals, I totally get the point of not having to purchase some kind of interface for the 22 different variety of things that are out there. And so most of the records go to medical records so that the data is there for registries and things that they need that way, but it's not really available for the ER doc by the time they've made their decisions. And so one of the other recommendations of this program is going to be for there to be a handoff page for the doc at the ER so they know what was going on. With this, well in the background, the data's slowly getting to where it needs to get to.
That would be nice for everything. In general.
Yeah. Yeah,
So-
that's true.
We have a quorum now,
Nice.
Dr. DeCarcer. So, as far as minutes go, we need a motion. Need a motion to accept the minutes? Second. Great. Service upgrades. So, we'll read these in. Threefold Educational Foundation for PAD application. ARC, various locations, PAD application. Bethel VAC, 12 lead. Kiwi County Day Camp, PAD. Carmel Sports Club, PAD. Stanford Fire Department, Narcan, glucometry, and albuterol. Noah's Ark, PAD. The Hamaspic School, PAD. Hudson Valley's Best Hopewell Junction, PAD. Hudson Valley's Best Beacon, PAD. The motion
To accept
to
it.
accept them? Moving along. All right. So the next service upgrade, the Town of Wallkill VAC RSI upgrade. So there was an application in, it was completed. Pam actually reviewed it. I looked through it quickly. It looks complete and accurate. So we have a motion to
Accept it.
accept it. Anyone? Second.
Which one?
We have to roll call vote that, or is it like just a roll?
I don't know that. Karen, do you know if it's a roll call or is that just regular vote?
No, I don't know if we have to do a roll call.
I think it's a regular vote on that.
No. So who made the motion to approve it?
Dr. McGurty.
And who seconded it?
Dr.
Okay, thank you.
All right. Anybody opposed? The motion passes. Easy. And then the next service upgrade, Town of Newburgh EMS ALS upgrade. Once again, this was reviewed. Pam met with the folks, and her opinion was that everything looked great as far as the application. I looked through it; it looks complete. Once again, for an ALS upgrade for the Town of Newburgh, they're currently DLS. Yeah, for the town, not the city. The city is already serviced by ALS.
Is
Okay, well,
anybody getting sports and stuff?
Yeah. Is there anybody from town of Newburgh here? Look at that. Who knew?
We're just going to put up our too.
Sure.
So my name is Chris Napolitano, I'm the executive director of Town of Newburgh EMS. Some of you that don't know our organization, we started back in 1967, of course, as an ER responding agency. Volunteer only. About 6 years ago, I was brought on to see if they can go their own way instead of subcontracting out to a for-profit agency. We found that we could, and I developed a hybrid program. Back then, we had no road staff at all. It was only about 30 volunteers, about 12 active. Presently now, we're about 6 years in. We have 35 career members, over 40 volunteers. When I first started, our call volume was around 2,500 calls a year, 2,800 calls a year. Last year, we almost had 4,500 calls, about 4,400 calls. Of our call volume, about 50% is dispatch ALS. Of that 50%, 17% is transport maintenance, due to a multitude of reasons, right? A lot of it is maybe no units available, everybody's tied up. We've worked well with our surrounding agencies, New Windsor, Montgomery, Mobile Life, Mobile Life, Amherst when they had units available, but it's time, right? We all know New York State's fastest growing population is the 65 and over population, surprisingly, right? We have some new housing units that are going in, community living, so we are busy. We are going to probably surpass 5,000 calls next year with that ALS number growing and growing. Just last month we did over 460 PCRs with that being ALS. So I'm a big numbers person, tracking it, and now it's time. We put it off, I will tell you honestly, because of our proximity to the hospital, right, from where we are. We're only a couple of miles down South Street, but now it's too much, and we're supporting our surrounding agencies. Montgomery's picking up volume. New Windsor's always busy. You know, we're really going out there. We've gone as far as Pine Bush to answer calls sometimes. So we're starting a fly car system. That's what we're looking to do. Hire between 12 and 15 medics. Our roster's been submitted, and that's what we're looking for. That's what we're looking for.
Any questions? Then can we have a motion to approve Town of Newburgh EMS ALS upgrade? Second? Anyone opposed? So no one opposed, the motion passes. All set. All right. I don't think, do we have any cases? Subcommittee?
No, nothing this quarter. It's doing too good a job.
All right. Good problem to have. All right, the DOH enforcement notifications. There's a bunch. Let's see. Amanda Van Heemstede Obelt for violations of Part 800, suspended for 1 year. Suspension stayed, 3 years probation effective March 11th, and a civil penalty of $1,000. Mackenzie Nickel, suspended as a result of Part 800 for 3 years. Suspension stayed pending completion of 3 years probation. Civil penalty of $12,000. $10,000 stayed. Nicholas Messina of Yonkers, New York, for violation of Part 800. Surrendered effective April 15th. Ryan Gittens of Brooklyn, New York, for violation of Part 800, suspended for 1 year, effective March 18th, and a civil penalty of $2,000. Arnaldo DeLees Jr. of Brooklyn, New York, for violation of Part 800, revoked effective March 18th, and a civil penalty of $5,000. And Jeffrey Ashdown of Modena, New York, for violation of Part 800, surrendered effective March 7th, 24. Helicopter Committee report.
We met this morning, and there have been no incident reports, communications issues in the region
since your last meeting. We discussed that over 2 years ago, the bill was passed to allow air ambulances to carry their own blood products, but the regulations still have not been written. And discussed that the ground bill for ground ambulances to carry their own blood products has moved through the Assembly and is now in the Senate being marked up.
Anything else?
I guess I can say here that we are administering tranexamic acid, TXA 2 grams now to hemorrhagic shock patients. And so I'll pass that along to the leaders of the collaborative to see if they want to do the same.
Yeah, so right now, if you've got significant hemorrhagic shock, you believe that's what's going on, you can, under the collaborative protocol, you can begin to infuse 1 gram of TXA, and by looking at the military data, basically you can just give, and the way the proviso works now is that you, as a medic in the field, can give that TXA if you're going to transport that patient to a hospital that will continue that TXA. So, you know, that you kind of got to know which hospitals are, you know, will continue the TXA. And it's also one thing you got to remind that hospital when you come rolling in the excitement of all that's going on with a major trauma patient that you've given TXA and they need to continue that protocol. However, sort of looking at some of the military data, it's pretty clear that we can probably very safely give the full 2 grams and call it a day. And you can bring them anywhere. Okay, so that's what we want to push up to, you know, to basically the collaborative protocol here. So.
Yeah, that would change the transfer destination requirement, so that's big.
Yeah, you do it, you know, you'd make that evaluation in the field, and you'd make the TXA call, and, you know, certainly you want to report off to the hospital you've given it, but it's a, you know, complete thing. It's done.
So the helicopter ships, if I'm not mistaken, in the previous meetings indicated that they do carry blood products.
Yes.
But you're saying something about that the regulations for carrying the products, is that a problem?
There have not been regulations written to require the air ambulances to follow those regulations, but the law passed, and so everyone is carrying it and using the process that is done in other states. So LifeNet is part of REMAC, which is a national company, and we carry blood in every state in which we fly, and essentially all the regulations are pretty much the same. Just New York hasn't put them to paper yet. So I'm sure that
So you don't need the regulations to carry it?
no, because it's law.
Seems a
Wild
little
West
weird,
out here.
but
It depends on who you ask. But if it's law, then it's lawful to carry blood products. And so we are. And then once the regulations are written, we'll have to meet those regulations, which we're helping to write, so we will meet those regulations.
I think the law for ground EMS is currently working its way through the legislative process. RTAC.
I'll defer to David because I was not able to make the last regional trauma advisory committee.
There was nothing specific that's not already known. It was trauma centers who had just gone through ACS verification visit, sharing their experiences so other trauma centers who need to go through their ACS verification visit could learn some tips and tricks and how to be successful. And then there was another trauma center that was preparing for a consultation visit. It was a level 3 center.
Who was it?
Northern Westchester.
Thank you. Northern Westchester, yeah, is level 3 applicant, so they're preparing for their consultation visit. Those are the two things that occurred. It was actually a rather short meeting.
One other thing that was mentioned there was the missed reporting for providers that was brought out to try to make sure that everybody's using that. To give the EMS the 30 seconds that they need when you come into the office and to come into the ER and to give their report. So to give it in a missed format. The only other thing that they mentioned is that there's a Westchester Medical Center Trauma Symposium that's going to be June 10th. July 10th, I'm sorry. Yeah, it was July 10th. Instead of the REMAC meeting, there will be the symposium.
If anybody wants the flyers on that, just see me after. I'll make sure I've got an email to you.
Yeah, I would, I mean, this conference tends to be really great, and it has been for, you know, a number of years. So I would, if you could at all make it, and the tuition is free. So, and it's open to everyone. So I would make it.
Price is right.
Speaking of Dr. John Holcomb is a national level speaker. He's a retired Army colonel. He will be there to give the keynote. I'm happy to pass that along.
QI? Do we have any PCR report?
Not exactly. For people that don't know, Jeff retired as of last Friday, so he's no longer working with us. And Nelson Machado is going to fill in for a couple of days part-time to just help us out with some of the things that are going on. And the only other important thing that's coming up is the 3.5 EPCR schematron is coming out. It has to be done by July 1 for every agency, and the agencies are responsible for getting that done, not the vendor. So they have to work with their vendors to make sure that they're up to date. And there have been several meetings. If anybody hasn't had the opportunity to attend them that needs to, let me know. I know there's one coming up, I think this week. It's either this week or next week that there's one coming up. So that's important. That's it for EPCR right now.
Protocol.
The protocol committee's been meeting monthly. We've been working on a few different things this year. Primarily, we started a group to review the RSI curriculum and program. I think the last time it was reviewed was 20 years ago. Mostly focusing a lot on what it means to actually be an RSI instructor. So that is being developed, and we'll report on that as it is fully further developed. Out of the last meeting, most recently, the question came up with the development of the 4-year state card, and a question for the REMAC is for the REMAC net control hours, do we need to increase the 24-hour requirement? Or should it remain the same?
So a quick background with that. So the state education regulations have been approved by CMAQ SEMSCO. They're going into effect. The state has to come up with some policies and procedures for a number of different items. But one of those things that comes out is that certification is going to a 4-year cycle starting the next certification period that you have. So you don't automatically go right now. When you certify again, then you'll get a 4-year card. The state is working on what they need to do. Are things going to change? Do we need to do more hours for the CME program? This and that, blah, blah, blah. So some of the discussion that came out of that Bob's talking about was to change the hours for medical control contact for the region. There happens to be a committee at the state level that is looking at all of the regions around the state to see who's doing what. Some regions have strict requirements, some regions have no requirements. Some regions certify their individuals, some don't know how many are in their region. So they're looking at a medium of what that might look like in terms of certification and the legality of certifying or not certifying if they can or can't. So those are some of the things that are happening at the state level with it. To that end, we thought that it would be good to put it out in front of the docs. One of the reasons that we had done this previously was so that physicians could get to know paramedics, paramedics could get to know physicians, we could talk about protocol and where that all looked, and it was
With the
part
advent of the
yeah.
webcast CMEs, we're seeing less and less of that.
Right, right. And so everyone thought it'd be a good idea to come here and have the folks here noodle it over and come up with a thought about it.
Anybody have any thoughts? I mean, not to sound, not to upset people, but when you think about it, if you don't change it, then you are effectively decreasing the amount of education that we require amongst our team here. So there's that.
There's also the history of the region where when we had it was the annual card, we had to do 8 hours per year. So, I mean, if you were to follow that model, it would increase by another 8 hours, I would say.
Right, and when there could be a requirement about, a maximum number of hours that could be done online versus in person. Because we want to make sure there's that interaction between the doctors and the provider. That was basically the substance of the discussion we were having. That's the intent of those hours anyway. And I know other regions like down in Westchester have to be call on it, but we don't have that requirement up here.
Do we know what the Bureau is doing with the senior certification program hours over that 4-year period? They haven't told you anything.
There might be a little bit of an increase in hours in different areas. I think what you're probably going to see is that they're going to mimic the national registry, so that if you do your state, you cover the national registry.
So just for clarification, the medics have a 2-year cycle?
3-year cycle.
We're going to a 3-year?
It's currently a 3-year, it'll be going to a 4-year.
Okay, so what were the requirements for the 3-year cycle as far as CME?
So it's based on hours. It's something like 20 hours of core material and 20 hours of non-core, and then additional 5 hours of extra material. It's something like that. I'm not completely
That's for
sure on the hours.
You're talking New York State?
For CME, yes, for New York State.
No, I think it just means our requirement.
Yeah.
Oh, I'm sorry.
It's just, it's 24 hours, usually 8 hours per year for the 3 years.
So I would say if you want 4 years, then not another 8 hours. That seems right.
Good. Is this something we need to vote on?
One of the other things that we had talked about was making it more protocol driven and less just straight education, so that everything was tied to a protocol when we went to the college. It was one of the other discussion things that we had.
Just one of the reasons we're going to a 4-year program is because it was difficult to do it every 3 years, and it was cumbersome on the medics, and we are losing a lot of volunteers and paid medics in the region. The state has lowered their requirements over the last 3 years. They've 12 hours over the last 3 years. I think adding another 8 hours would be a little bit unfair in the sense that there's enough hours to be made online. Like adding another 8 hours, I think would be a little bit.
It's not really adding 8 hours, it's keeping it the same. That being said, we can vote on this next meeting.
Yeah. But I do think that I do think they should be linked to some sort of protocol, and maybe having a requirement that they are an additional 8 hours. Maybe they need to be in 8 hours of call audit that are specifically protocol based. Might be worthwhile to make sure that they're getting this focused education on top of it.
I feel like the call audits are definitely very beneficial, not just with FaceTime, but kind of in-depth discussing whatever the clinical issue is.
Just from Rockland County standpoint, we don't have call audits because our hospitals don't do them. Yeah, so I mean, there's something to look at with that. I kind of agree with the gentleman over there, but just to regulate it, we don't have call audits.
Bring up
the agency can put those on there. The agency can put those on as well.
Yeah, I think that it's encompassed on the medical director to interact with their agency. Our med directors meet with us all the time. I think it's part of your, if you're a paid department, you have a medical director that should be interacting with your providers and maybe meet that requirement. The med director is that they're going to interact with the providers, because a lot of these CMEs you go to, it's not really interactive, but if your med director is there looking at your PCRs, you get a lot of good feedback from it. We pack our CMEs, when Dr. Fleece is there, we have 45, 50 people show up. It's just really good interaction. And I think that the quality of the CME is more important than the amount of CME you're having.
Correct. And what Aaron said actually is pretty significant and important. The onus is kind of on us to have audits as well. I mean, obviously the agencies can do it, but it used to be that every hospital kind of did it monthly 10 years ago, and that totally fell off even before COVID, and COVID made it even worse. So we really should try to do that on our side.
Just from somebody who's totally not involved in this, but if you win your fourth, if it was a 3-year cycle, when you went into your renewing cycle, 4th year, you have to do the 8 hours anyway.
I didn't understand.
You did a 3-year cycle, 8 hours each year.
Right.
And you went to 4 years. If you were still in a 3-year cycle, when you went to your next 3-year cycle, in the first year of the next 3-year cycle, you'd be required to do 8 hours.
Correct. So really, I mean, yeah.
There's nothing, we're looking for retention, the state's looking for retention, retaining paramedics, so.
Yeah.
I mean, and we did discuss, I think it's going to be very important to make sure that there's a protocol element, because there's a lot of CMEs that are put out there on Zoom right now that's just, the residents have to give their educational speech, and there's nothing, they don't even know what the protocol is. Right. So they don't even know what we can do. So I think if it's put in writing, that there has to be a protocol.
Please keep your camera on, half of the screens are blank.
Yes.
Or you can look at fan.
Yes.
All right, so something to think about, and then at the next meeting, we'll make a vote. Alrighty. Anything else, protocol committee?
Nothing.
CMAC report?
Everybody should have gotten the notes that I sent out from the last MAH00075. If you haven't gotten, please reach out and we'll make sure that you get them. I'm just going to make a couple of highlights. The EMTCC is sunsetting, and so down the road you'll no longer see EMTCCs. People will have to bridge to either the paramedic, which is free to do online with local skills testing, or drop down to AEMT. And so that's coming down the line. That was voted on by all of the committees in CMAH00075 the last meeting. Was reiterated this one. There's a lot of legislation out there. Of course, I'm sure you've all heard that none of the EMS items made it into the governor's budget. And so it's now on the legislative floors, mostly for treatment in place or transport to alternate destination, mobile integrated healthcare, and extending Medicare add-on payments for ground ambulance services. So some of those have made it through the Senate and are in the Assembly. And so we're running up towards the end of the ability to have these things voted on during this legislative session. But that's what's happening with those items there. On the systems committee, they're working on the ideas of definition of need and looking at system and agency performance standards. So you may see some of those coming down the line at the agency level in terms of reporting monthly out for their performance abilities, and also on quality, looking at 3 or more SEMSCO approved quality metrics to implement those and report monthly. So those things are coming down the line for agencies to do, which is great stuff. In terms of quality metrics, the quality improvement guide is now on the state website, and all of the state metrics are up there as well. And so the numerators, denominators, all the process accounting group is all on there. And there's actually not a great definition of patient or patient contact, not only for New York State, but for many states in this fine union. And so we came up with the definition of patient and patient contact. I'm going to read that out real quick just so everyone here Is comfortable with that? Patient is defined as a person encountered by EMS personnel with an actual or potential injury or medical problem. Encountered refers to the visual contact of the patient. These persons may have requested an EMS response or may have had an EMS response requested for them. Due to the hidden nature of some illnesses or injuries, an assessment should be performed on all patients. For patients initially refusing care, an attempt to evaluate the individual, even if only by visual assessment, is expected and must be documented. The reason this is important is that the committee is working on this process going to regulation, so that it's a little bit easier, and then the state will come up with some policies from there. So then we will have a definition of patient contact from the state. We talked about the IGEL program. There was discussion about the use of opioid antagonists, naloxone and nalmefene. There was a really good discussion, and it ended up with the group deciding to say that naloxone will be the only opioid antagonist used in New York State. And that was sent by CMAC to SEMSCO and approved at SEMSCO also. We talked about blood products. There was a lot of discussion this time around on the length-based resuscitation tapes and the doses and weights being appropriate for pediatric patients. Some of those were not aligned previously, and so some of those are not coming out to be better aligned. We talked about first responder mental health, and that was it. Unless there's any questions by this group.
Are they changing the length-based resuscitation tape weights?
Yes, they're ensuring that
bigger America.
The dosages and the weights are all appropriately met, so that the dosages match the weights.
New business. So it's a couple issues, items to bring up. The first is in the new protocol change. It was brought up the issue of antibiotics for open fractures for extended extrications and prolonged transports. There is in the protocol change, there's a BLS option for open fractures that is subject to regional approval. And so one of the agencies had asked if we would be approving this locally. And so the protocol is to give moxifloxacin or cefazolin. Well, moxifloxacin is PO. I just realized we were talking about this and saying it was all PO, but it's ANSEF, which is not PO. It's the other agent. So the idea being that, an open fracture is subject to getting infected, the longer it's not managed. And so if somebody has a prolonged extrication, starting the antibiotics early may be beneficial. It seemed the question when we were talking about this during helicopter committee is if you're giving moxifloxacin orally, the amount of time it takes to get absorbed, you may be at the hospital by the time it starts working anyway, at which point, IV antibiotics could be administered. Thoughts?
There's an IV formulation of moxifloxacin. There's an IV formulation.
Correct. The protocol said oral though, and it was open. It was a BLS protocol. But what I didn't understand, or I didn't appreciate until now, is ANSEF is in there as well, which is not oral, obviously, or maybe not obvious. Yeah. Do you know? So.
Have there any studies that indicate time as being a critical factor later in osteomyelitis or?
That's a great question. I don't know the answer. I don't know if anybody else does.
Yeah, no, there's data out there about IV administration of antibiotics in open fractures.
So theoretically, it could be.
What?
IV administration.
Yeah, IV administration. Now, there is some military data that because often field medics in the military will pop those two, moxifloxacins in your mouth if you've got, if you've got a blast injury with an open fracture. But also their transport time to definitive care is unclear. It could be hours, it could be, so they felt like this is something that can be done in the field quickly, and there is some data to support that that's probably, tends to minimize, a complicated infection bone, from open fracture. So I think that may be where this thinking is coming from, giving it as a, BLS, as a BLS skill.
Some of those studies had to do with specific IED blast injuries and, contamination, terrible contamination of sand and so forth, which may not necessarily be the case with a open fracture,
So Mark, the other piece might be that as a BLS provider, you can't give an IV medication.
Yeah.
Right.
Right.
But the bioavailability of those antibiotics, the bioavailability of those agents is almost the same, IV or oral.
So, in addition, our role is really to approve it, but it's up to the local agency whether they would actually decide to carry this in conjunction with their medical director. So it's not a mandate if we approve it.
I believe in clinically appropriate treatment, and giving a pill to an open fracture in the field doesn't have any clinical benefit compared to waiting to get actually antibiotics in. By the time it gets absorbed and through the liver and becomes bioavailable, you're already in surgery. So I'm not sure you would need to worry and have the expense and the training and the education when there's multiple other things that we can be focusing on rather than giving an antibiotic pill to somebody with an open fracture.
What's the definition of delayed extrication?
What's the definition of a patient? They're not even at extrication.
We just did that.
Philosophy 101.
You see an open fracture.
Yeah. Are we talking 30 minutes in, the backseat of a car, or an hour and a half off of a mountain, The vast majority of these cases are not going to be an hour and a half off the mountain.
Correct. I think we're talking about a very, very small subset of patients in the entire Hudson Valley region, per year, probably 10.
And we're also talking about how are we going to be administering this PO? Are we now going to be preparing some kind of beverage for these patients, which are now NPO, or no longer NPO, for likely having surgery for an open fracture?
In our discussion earlier, during the helicopter meeting, it was brought up that there's a pediatric version of this as well, and then
kids don't swallow pills.
Is there liquid formulation?
Some people may be carrying their own beverage that got them into the situation in the first place. But still, I think, is there a real true clinical effect? And if there's not, then we shouldn't bother. That's my thought.
So, this is interesting, because usually everything we talk about is unanimous, one way or the other. There's some debate. Should we have a vote? Or do you want to keep it for discussion?
If you want to keep it open for another discussion.
For the guys,
Pending
Keep it
research.
open.
Yeah.
for the IV antibiotic, it also says as regionally approved. Does that have to be per agency, or is that just for the regional approval?
Normally what we would do is the region would approve them, and then each agency would notify us with their medical director saying that they're going to utilize that, so that we know which agencies in the field are using it, which aren't. So that would probably come under the same type of a process as similar to an adjunct.
so it wouldn't be a mandate.
Right, there's no mandate on it either way.
So,
So for ALS agencies that might want to use the IV approach, if appropriate, that would have to be a regionally approved medication, yes.
yeah, just as, the same as moxifloxacin. So what we could do is, once again, table voting for, till the next meeting, and in the meantime, maybe someone could get some research that, you know, shows whether it's beneficial or not. Obviously, somebody thought it beneficial, to the collaborative, so I'm assuming they have some, but I don't know it.
I don't even know what the discussion was at the collaborative, that was what it was. Usually attend those meetings, I didn't hear anything.
So that's one item of new business. The next item was brought up, is Anthony here from Beacon? Oh, yeah, so you were part of this discussion, or do you want me to bring it up, or?
So, I'm Dr. Ostrowski. I am not the medical director, but I am the president of the board at Beacon Optics. We became an advanced EMT agency 3 months ago, which is the first in Dutchess County, and the second in the Hudson Valley REMAC area, with Fort Jervis being the first, and it's probably its second year. The advanced EMT program is now the intermediate program in New York State. Has not been very active in this part of the state. Other parts of the state has been very much more active. The protocols are well defined in the combined protocols. Has decided that when the project came out last year, the TAG study on sustainability, about ways that we could expand our workforce. So one of the ways to expand the workforce was to go the ALS route. But I did not want to parasitize existing medics, because that's exactly what would happen. We would just be medics who were working elsewhere, usually in our area, commercial agencies, and we'd be putting us and wouldn't do anything. So I had two reasons for doing this. One was to increase the availability of a higher level of training to put them on the street. And the second was the path forward for my personnel, my volunteers and my full-time paid people, which is mostly my personnel now, to give them a career path forward. Higher salaries and a way to become confident that they can now become AEMTs, and then they can become medics, move on to the medic level. Many of what I've experienced in my time there is that many of these guys lack confidence. They have great BLS skills, they've been doing this for a long time, but they need an intermediate level. And the AEMT seemed to me to be a great place for them to start. And to date, that is what's happening. I think because the program is new in Southern Dutchess, that we've run into some questions, and those are the questions that were submitted to you. One question was, in the transfer of care policy that HV REMAC has, it's very unclear about when a medic can transfer a patient to, well, it's totally unclear, it's not in there, to an AEMT. The other questions that we have are, one is, can a medic transfer care of a patient once a procedure has been instituted, which is appropriate to the AEMT level, and that procedure is going to usually be an IV. So if an AEMT starts an IV, does the medic transfer the patient over to the AEMT for care and transport? The second issue is when the AEMT can cancel the medic because there is a two-tier response system required. So ALS and BLS are dispatched at the same time. And the question is, can the AEMT cancel ALS? And to me, the idea of sending everybody to the same call doesn't make a whole lot of sense. you know, that there's got to be a lot of clinical judgment. If the, you know, if the AMT can operate within his scope of practice, his or her scope of practice, that they should be able to, just as an EMT basic, can cancel a medic. So the question really would be here, if the AMT can cancel a medic, but has to start an IV. So these are very basic questions. I think they're easily answerable, but I think that that this is new to the region, and issues have been raised, some of which may have been from our commercial agencies. What I have today also from BVAC is a different Anthony, who's an AMT. He's practiced in other parts of the state, and I wanted him to give us the perspective of how it's done elsewhere. If we have a few minutes.
Yeah, so I actually practice in the central New York region, in the Tompkins County area. Relatively rural, larger transport times to our area hospitals. Central New York also has a transfer of care policy that is quite vague. But with that, it essentially allows the AEMT to cancel the paramedic when it's one of the protocols that are within, basically where there's overlapping scope of care, as well as when it's appropriate. You know, when we do not expect the patient to decompensate or any additional interventions to be necessary. Basically all for the purpose of increasing the number of ALS providers on the road, putting the paramedic back into service when it's appropriate. It does require the AEMT to, you know, make clinical judgments and determine what's most appropriate for their patient. But it has worked quite well, and it has certainly improved the number of paramedics that we've had on the road by allowing them to be put back into service when certain interventions are warranted, but not fully up to the level of whatever may be appropriate for that specific protocol.
Correct me if I'm wrong, our verbiage of that section 6 doesn't actually mandate that the paramedic transfer doesn't. Or
no, it just
has to be canceled.
It says paramedic and EMT and ALS and BLS. There is no mention of AMT or very.
Right.
Right. In the policy, in the transfer of care policy. In the part 6 of the medical control plan is basically that they have to be dispatched simultaneously if they're in an EMT service. Right. If it's under a paramedic service, they have to be dispatched simultaneously. Doesn't really state it. That's not.
So I have my opinion on it. Does anybody have any thoughts? From my perspective, currently an EMT can cancel a paramedic if they get to the call and they don't think it's indicated. And so now we have somebody with more training canceling paramedic. So I don't see how it would be that much different from that perspective. And so I don't think really there's anything that says that they can't. And there's no reason that an EMT can't cancel, or an AEMT couldn't cancel the medic if they got on scene and realized that they didn't need any higher level of care. That being said, ultimately it's a clinical judgment when you do that, and you know, you own your decisions. So that's my opinion. I don't know.
I agree.
And with regards to turning over a patient, the scope of practice is that they can manage an IV. And so if an IV is the only thing that's been done differently, and it's within their scope of practice, then it wouldn't seem extraordinary for them to be able to, I don't know if that's the greatest word, but it would seem that they would be able to, you know, do that.
You know, in other regions, like in Port Jervis, where they don't have ALS available, no problem.
Right.
You know, they do what they have to do. Here, because we have AMT agencies and available ALS agencies, it goes raised issues. Those issues need to be clarified. What I would like to see is, I would really like to see this AMT program, for me, is to really grow to other agencies and you know, such and Dutchess County. I think it's really, just like physicians have physician expanders, there should be medic expanders. And AEMTs are great medic expanders. I mean, you have good physician expanders, you'll have a mix. But it's up to us to train them get their critical thinking skills appropriate to what they're doing. They all have to go, their training above the level of basic is about 200, about 200 to 300, depending where you are, about 200 to 300 hours of classroom, ambulance, and hospital time. And they have to pass their skills examination, and they have to become nationally registered, which is not an easy thing from what I hear. So I think it's a very good program, and I think it should be expanded, and we should make, and I would hope that this agency, this board would be an advocate for how we can expand our workforce and give our underpaid and overworked workforce a path forward.
From the discussion, I don't know whether we really need to change the verbiage of Section 6, because currently, from what I understand, you're allowed to do both of those things. It's just, it may be that there's some misunderstanding as to whether they are or not, but it's the current practice.
Because the transfer care policy says that a medic can transfer to an EMT basic if that's appropriate. A medic can transfer to the same or higher level of care, but it says it's silent about whether they can transfer to an advanced provider who's not at the level of ALS. And apparently, from what I understand, on the street, there are a number of medics who are uncomfortable with that. They don't feel that it's explanatory enough that they have the right to do that, given the current transfer of care policy.
Specifically based on the verbiage presented in the policy, not at the provider level. I don't trust that provider. Specifically, with the wording from the regional policy, there is the concern that we're exceeding.
Put up an amendment for
Put out the verbiage on the email, you vote on them in September.
Sounds good.
Would you like us to provide verbiage for the transfer care policy?
If you have a suggestion, that would be fine.
And that's what we do.
Seems easy to draft.
Find and replace.
I have a couple of things, I guess. So just a report from the Westchester REMAC. A couple issues for us. One of the things is, and you have the same protocol here basically in the Hudson Valley, and that is around stroke. Okay, so basically whatever diversion or destination call based on what you find in the field. Does this person go to a primary stroke center or an interventional stroke center? So we wanted, there's been a couple I think 3 major papers that have sort of come out and raising some questions about whether we're really doing our patients a favor by going by primary stroke centers and going just to interventional stroke centers and so on. So we wanted to try to, we're all operating in an environment in which people are basically diverting to a higher level based on what they find in the field. And the question is, again, trying to get the data to evaluate this and see whether we're really doing patients a favor. So, it's a huge challenge because, as folks have said, it's hard to get stuff from the hospitals. What is it that we're exactly looking at? But we're trying to take on that challenge and see if we can make some sense out of this program that we all instituted, and now everyone's doing it. And is it really beneficial for the patient? So that's one thing that's out there. So,
can we get the studies sent out? Because I only read one.
Yeah.
And it may not be one of those 3, but it was done in North Africa. It just didn't seem like it applied.
Well, I thought it was Spanish stuff. It was. Anyway,
You're right.
it was Yeah, it was Spain, the Spain study. Hey, I can get the stuff. I mean, I did not bring this to the REMAC, but I can get the studies and
Yeah.
we'll put them out there so that people can take a look at it. I don't know. Well, I don't want to insinuate on the studies, but I felt they were a little weak. But anyway, that aside. The other thing that's going on in Westchester is we have approved for the community to try to improve the community paramedicine program. We have one agency that basically works with one hospital, and it's a certain protocol, a certain subset of patients, and what it is primarily patients who have fall under certain disease categories, and that's, you know, pneumonia, okay, COPD, okay. So here's the thing: patient lands up in the hospital and gets treated for, let's say, community-acquired pneumonia, and then they get discharged home. There's now, you know, quite an incentive for that hospital to make sure that that patient doesn't come back within 30 days. And so, because it was like, okay, you know, you bring the patient in, you gave them the IV antibiotics, they're looking good, their pulse ox is straight, they don't have a temperature, their white counts drop back to normal, and out the door you go, okay, as quickly as possible in this day and age, you know, and you're back home. But if you're not providing follow-up care, if you're not making sure that patient is able to fill their prescription, if you're not making sure if they need, let's say, pulmonary therapy or whatever it might be, and that patient bounces back to you, and a certain number of those patients bounce back to you, all of a sudden your Medicare reimbursement for everyone goes down. So there's a big incentive for the hospital to try to get this 30-day readmission thing down. So in working with the paramedics in a community paramedicine program, if the patients who are been discharged and you know, fall into those certain disease categories, they are instructed that if they're not feeling well, they're not doing well, they are not able to follow up with their private doctor, whatever it might be, that they should, rather than call 911 because they're starting to develop a cough and a fever again and feeling short of breath, they call this number, and it happens to be at White Plains Hospital, is doing this sort of pilot program, and they find out, so you talk to a online physician, and then they dispatch the community paramedicine folks. So the community paramedicine get there, they evaluate the patient, and they say, hey, you know, maybe what we need is, you know, a dose of IV antibiotics here. Okay, this is in conjunction with that online medical control doc, but not an online medical control doc in the ER. Okay, so in other words, this doesn't fall onto the online medical control doc in your local ER. It falls specifically to the online medical control doc at White Plains Hospital Cares. And with the telemedicine interface, they make a decision to give that patient some IV antibiotics. Okay, and there's a certain set of antibiotics that those paramedics have been trained on. Okay, they have certain protocols on, and or guidelines on, and they go ahead and give that patient the IV antibiotics and or other treatments. Maybe they'll give them an aerosol, whatever, other stuff that's sort of more routine, and prevent that patient from bouncing back to the hospital. So anyway, we have approved that, and so that program is going forward, and we will see and evaluate what the outcome is. But I think it's, you know, I mean, this is one hospital and it's, you know, one set of patients, but I think it may help in modeling some of the community paramedicine stuff that we can get into in the future, which I think would be very helpful.
They let it fall because of funding, but I would love to know, how are you guys funding that?
It's basically being funded in an agreement between the hospital and the paramedic and the
And the agency.
agency.
Yeah, that's excellent.
Right.
Oh, yeah. That's awesome.
It's a Montefiore facility. Isn't White Plains Hospital Montefiore
Anyway,
facility?
that's all I
something
have.
I don't know.
I think,
You know, might be applicable to us at some point.
Yeah, yeah.
You know, we don't, I think, so Rockland's not operating.
It just, the last one that they had was with Good Samaritan Hospital, and it just like tanked because of funding, but it would be great to get that back. I agree with you. That's like the wave of the future. Absolutely.
We had that.
With a lot of people out of it.
Financially, I think we ran out of money, so,
It was an excellent program, though.
NIAC had it with you
Yeah,
guys initially.
NIAC's funding went down first, but yeah, that was excellent.
So, we'll see. That's all I have.
Follow. Any other new business? Open forum? Speak now. Do we have a motion to adjourn? Second. Thanks, guys.
Nice job.
Yeah, you do.
I can't sit up this thing.
It's gonna